Hello, welcome to this short presentation on chest pain for your NAC OSCE History and Physical Examination Station. My name is Vigneswaren Rajaendran and I'll be taking you through this presentation to give you a little rundown or a brief outline of how you should be preparing for your chest pain station. And I remember when I started my preparation, chest pain was the first topic that I started with, and I know many of you will do the same as well. So I hope in the next 10 minutes or so this will be useful to you. So just before we start, some points to remember. Always read the case and instructions carefully. Both history and physical exam must be focused. Have a template in your mind, but reorganize and be prepared to be flexible. I'm saying this because many of us sometimes become very schematic and very rigid in our presentation, and this won't be nice and won't be proper to show in front of the examiner. We have to present ourselves in a way that we are flexible and we treat every case differently. So please have this in your mind, and importantly, give ample room for empathy and listening. It is not all about your medical knowledge. Differentiate acute versus chronic, emergency room versus clinic setting, traumatic versus non-traumatic, and finally, and probably the most important for this station, will be differentiate between cardiac versus non-cardiac symptoms. And your main aim should be to filter out any warning symptoms. So what are the differentials for chest pain? I've divided into acute and chronic. So acute, of course, what stands out first, and our main aim is to rule out acute coronary syndrome, which includes unstable angina, STEMI or non-STEMI, aortic dissection, pericarditis, tension pneumothorax, cardiac tamponade, pulmonary embolism, pneumonia, panic attack, costochondritis. As for chronic causes of chest pain, we have stable angina, gastroesophageal reflux disease, peptic ulcer disease, esophageal spasm, cancer, herpes zoster, congestive heart failure. So this is just a slide to show us what are the common non-cardiac causes of chest pain with some visual aids. I think I mentioned this in the earlier slide. Esophageal reflux disease, muscle problems, ulcer, lung disorders, bone disorders, deep breathing, pleuritic chest pain, emotional disorder, and esophageal rupture. So what is the general outline of history taking for chest pain? What I usually do is go according to the onset, cause, and duration. Then since it's pain, I will use this mnemonic, which is PQRST. Pain, quality, radiation, severity, and triggering factors. And then you ask if this is the first time you're experiencing such a pain, and also you'll ask about precipitating activity versus whether it was present at rest. Any local symptoms, any associated symptoms, and you will also ask about cardiovascular systemic impact and risk factors for cardiovascular disease. So this would qualify as a comprehensive history, and if time permits, it would be great if everyone can do this. This would include past medical history, hospitalization, follow-ups, medications, explore about substance use, smoking history, family medical history, social history, questions such as with whom do you live, are you in a relationship, and how is your social support like, and in terms of work, what is the nature of your job, is it stressful. And you can also ask about general screening, like have you been screened for cervical cancer, breast cancer, lung cancer, especially for smokers, prostate cancer, colon cancer. And you can ask about the person's diet and also exercise history. So what are the local symptoms for chest pain? You would want to know if the patient is also experiencing palpitation, heart racing symptom, dizziness, sweating, loss of consciousness, any nausea or vomiting. As part of the associated symptoms, we can ask about cough, fever, heartburn, any acidic taste, history of trauma, history of long travel. Are you experiencing any lower limb swelling, any lesions, and finally any constitutional symptoms such as weight loss, night sweats, or any bowel habit changes. So what is the impact of cardiovascular disease? So we have to explore if patient is also having any sexual dysfunction, any vision changes, pain after walking, or claudication symptoms. Now for the physical examination of the cardiovascular system, we'll start by asking for vitals, if not already given in the question stem. Learn to prioritize which signs might be of most importance. Check for any hemodynamic compromise. For this, you will check the pulse for volume and rhythm. So you will want to see if there's any tachycardia, weak or thready or low fill pulse. And you'll check the blood pressure if there's any hypotension. And you will also check for any prolonged capillary refill time, clammy extremities or pale looking, and also if you look for any reduction in the jugular venous pressure. Other specific findings include murmurs, carotid bruit, muffled heart sounds, or pericardial rub. Also, you will check for pedal edema and pulmonary edema for signs of heart failure. So now for the post-encounter probe, the candidate might be asked for differentials, the diagnosis, investigation, and also management. So as part of the investigation, for a patient presenting with chest pain, we could order complete blood count, lights, urea, creatinine, cardiac markers, troponin, amylase, lipase, liver function tests, coagulation profile, lipids, and you can order ECG. As part of imaging, we order chest x-ray, echocardiogram, coronary angiogram, and stress test. So now comes the part of interpretation of ECG. Frankly speaking, this used to scare me. I'm not the best at interpreting an ECG, but I remember when I was preparing for the exam, I used a lot of resources on YouTube and also read some books, Toronto notes, basically very simple stuff because you don't have much time to go deep into ECG interpretation. So I would say use a systematic approach, memorize a few details, and ultimately try to understand it. So I watched this particular link. If you have time, you can do that, but there's so many resources out there. This particular link provided 10 steps. So important points to note in the ECG are the rate, whether regular or irregular rhythm. Do you see any P waves, any ischemic changes like ST changes, Q waves, inverted T's, bundle branch blocks or right or left bundle branch blocks, ventricular hypertrophies, heart blocks, the morbits 1, 2A, 2B, and type 3. So this is an example of a ST elevation MI, and you can clearly see from V1, V2, there's already very clear ST elevation, and important also to note reciprocal changes. So you will see ST depression in 2, 3, and AVF. Okay, so it's very important to note these changes. And now this is a atrial fibrillation ECG strip. One of the most important points to remember is it'll be irregular rhythm. So it either is irregularly irregular or regularly irregular. Okay, and you will also note that there won't be any clear P waves as well. And this is a pericarditis picture. So what we see here is a diffuse ST elevation. So if you can see from V3, V4, V5, V6, also on lead 2, you can, and AVF you can see a little bit. So what is the most important here is diffuse ST elevation with no reciprocal changes, and a very clear fish hook sign that you can see of the ST segment. This is a heart block, and for heart block you always look at the PR interval. There will be elongation of the PR, and remember to learn also the criteria which differentiates type 1, type 2A morbids, and type 3 as well. This will help you to in differentiating this various type of heart blocks. Okay, so this is a picture of a left ventricular hypertrophy. You can see from the deep QRS complex. Okay, you can see it from your V2, V3 components. It's coming down, and also look at your 2 and 2, 3 leads as well. So that shows ventricular hypertrophy. This is a right bundle branch block. It's a benign condition. So how do you remember this is you will remember marrow. Okay, so it's M-shaped, the QRS complex in V1, and in V6 it's W-shaped. Okay, and it's different from LBBB, which is William, so it will be W and M. Now we come to the management. Assuming it is a MI, what you would do is, as acute management, you would stabilize the patient, and this means setting an IV line, and then you will administer morphine, oxygen, nitrates, and also aspirin, and you will only do this if there are no contraindications. Then you would refer cardiology as soon as possible, depending on the recommendation that's given, whether you would prepare for PCI. This is, you have a particular time frame for this, which is 90 minutes. Otherwise, you would do a thrombolysis. So what are the long-term management? You would start the patient on anticoagulants, statin, and also beta blockers. And then there might be a bypass surgery if patient fulfills the requirement. Then most importantly, you will advise on risk factor modification, and this is through proper diet, exercise, and also smoking cessation, also cutting down on alcohol. Okay, and you would set up regular follow-ups, okay, to check the progress of the patient, and also make sure that patient does his regular screening. Thank you everyone for your attention. I wish you all the best for your exam, and hopefully this presentation has given you a little bit of a rough idea on what to expect, and hopefully we'll get you started with your first topic, chest pain.